Good afternoon. Welcome back here at ESCMID Global TV. My name is Judith Cohen. I am the host here at ESCMID Global TV, and you are watching our final broadcast for today, the second day of ESCMID Global 2024. And I'm very pleased to announce that I have two live guests here with me in the studio. Both are specialists in internal medicine and intensive care medicine, and we have invited them here today at ESCMID Global TV to talk with them about the presentations they gave back in February already during one of the pre-ECMID days. On Leap Day, February 29th, they spoke in a science track that was organized by the British Infection Association, the BIA, and the ESCLI, which is the ESCMID study group on Legionella infections. And they talked about diagnosis and management of infections in critical care. And because this is a very relevant topic, I'm very pleased to see you both here. Jeroen Schouten on the far left and Despoina Koulenti closest sitting to me. A warm welcome to you both. Jeroen, you are working as a specialist in internal medicine and intensive care at the Radboud University Medical Center in Nijmegen, the Netherlands. And you, Despoina, are in a similar role, but in the King's College Hospital Foundations Trust in London, in the UK.
Thank you. It's a pleasure and honor to be here with you.
Well, I think the pleasure and honor is ours. So it's really, I'd really like to have a chat so our viewers can get a sense of what they missed at the pre-ECMID day, and also see just hear a little bit of what's relevant in critical care or infections in critical care these days. What are the challenges lying ahead? And what you talked about. So, Jeroen, can I start with you? What do you feel are the largest challenges in your field of medicine at the time?
Well, I think what we both recognize is that the ICU is a very special place, right? So it's a place where, first of all, the patients are different than in other places in the hospital. These are severely ill patients. They are often immunocompromised, so they are at high risk of getting infections. They also often have multiple organ failure. And that makes that these patients require very specific attention for us as intensivists, but also need a special attention from other people that influence decision-making in the ICU, like pharmacists, like ID physicians and microbiologists. Yeah. So that's one thing. The second thing is, and I think it's also important to mention, is it's not only the patients are different, also the bugs are different, right? So we find a different type of bugs there. There's more resistance in those bacteria, and that's mostly because these patients are often ending up in the ICU after a long track where they've already been treated with antibiotics, where maybe the resistant bugs have become more apparent. So it's often more difficult to treat them. And finally, it's also important to mention that the doctors are also different, right? So ICU physicians are a special kind. They have interest in infectious diseases, sometimes and sometimes not, and they need to work together in multidisciplinary teams to treat these patients. So I think that's why ICU is such an exciting place, but also a challenging place to work in infectious diseases.
Well, which proportion of patients in the ICU have infections? Is it half? Is it more? Just to give me a sense of magnitude.
Can I? Okay. So studies that they have been done in the past, they say that half the ICU patients are prescribed antibiotics, and some of them antifungal as well. Yeah. And the proportion of hospital-acquired infections that they are ICU-acquired infections are much higher than in the general ICU wards. Yeah. Also, half of the hospital-acquired infections are onset in the ICU. So it's a very special place with very increased risk of acquired infection, and also a place that the burden of infectious diseases is higher.
Yeah, because of the complications?
Because of the patients, they are, as it was mentioned by Jeroen, they are more vulnerable. They spend, usually they end up in the ICU from community with very severe underlying conditions, or they are several days or weeks in the hospital, they deteriorate and they end up in the ICU. They are already frail, they are already colonized, and several times they have taken days and days of antibiotics, and they end up colonized with MDR, and the intensivist has to deal with that.
Yeah.
That's why ICU has also such a high percentage of antibiotic use.
Yeah, yeah. And Jeroen, you also mentioned one of the differences between ICU care and normal hospital care is that the bugs are different.
Yeah.
Of course, there's probably also regionally or per country also different.
Yeah.
But the bugs are different, but are they more difficult to treat? Or do they come with larger complications, or is there more antibiotic resistance?
So it's obviously a little bit different. It's a little bit dependent on what the type of patient is. Sometimes you have a patient who comes in directly from the outside and has pneumonia and is admitted to the ICU directly, and then obviously you would expect the disease to be caused by pathogens that are originary to the community. So those are not difficult to treat infections. But as Despoina said, many of the people come in later in the process. So they're first admitted in the unit, then they are getting colonized with pathogens. Maybe they also get colonized or transferred pathogens to them that are resistant. And the worst thing is, even if they are in the ICU for, let's say, another reason, for an accident or for a neurosurgical condition or whatever, then they afterwards can get an infection. And due to that infection, and that infection is often caused by severely resistant microorganisms. And then we get into a real conundrum of treating. So the main challenge we have, I feel, is also to think really critically about when we need to treat patients in the ICU with antibiotics and when not. Because they're so severely ill, we tend to treat them quite quickly with antibiotics. While maybe, as you said, rightly said, yes, a lot of patients in the ICU have infection, but a lot of patients also do not have an infection, and they are still treated with antibiotics incorrectly.
If, for example, a patient with a sepsis, and you don't know yet if it's due to infection, but you see the whole host immune.
Or not even sepsis, maybe it serves for other reason, and because we're afraid that the patient might deteriorate, we might start antibiotic faster, even a percent of the cases do not have sepsis. And I will corroborate what Jeroen said, and it's very important to decide when we're going to start, or if we have to start because we are worried not to delay antibiotics, to decide, reassess quite fast when in 48 hours, 72 hours, to see, should we go on with antibiotics? Should we stop antibiotics? Should we go for more targeted treatment? So it's very important, to make steps and following steps and thinking and rethinking, antibiotics, yes or no? Should we continue or should we stop? And sometimes because we feel, especially if the doctors are not very familiar with infectious diseases, made feel that, how can I stop antibiotics? They are afraid that the patient may deteriorate if they stop. But it is the patient needs or doesn't need the antibiotics. Or if initially it needed and you have given the correct dose, fast, how long we should give the antibiotics? So to decide maybe to decrease the duration of antibiotics. And another thing is it only antibiotics that I should give to my patient? Sometimes the patient needs source control in the ICU, not only antibiotics.
So the time frame for diagnosing is really actually quite
tight.
And I can also imagine, Jeroen, that the collaboration with other specialists in the hospital is extremely important for this very vulnerable patient population. Because if I understand correctly, you sometimes start, or often maybe start, antibiotic treatment empirically, just we need to do something. and
Absolutely.
we have to wait for the clinical microbiologist or to come through with results.
Absolutely. So
Yeah.
the relationship between the intensivist and the microbiologist and the ID physician and the clinical pharmacists who make part of the teams in the hospitals, very relevant, because we cannot expect this intensivist to know everything. Let's be honest, the intensivist treats from trauma to whatever, an ischemic cerebral event, to very severe sepsis. So if you want, the intensivist is often a little bit the general practitioner of the hospital.
I was just going to say.
We do everything. So it can't be expected that we know everything. So we need that input from the ID community. And I think it's very important that so when we make decisions about antibiotic therapy, for example, stopping or continuing or changing, that we do that together with them. It's never a decision by ourselves, and I think it's a decision that has to be informed by cultures, of course, very important, by the previous medical history of a patient. So it's really a combination of clinical and microbiological science. And we do that ideally in patient meetings where everybody is present, right? So where you can really discuss this. And the studies that we've done show that if you make decisions in a sort of a shared decision-making model, that they're more effective and they're more likely to have better outcomes in patients in the ICU.
Yeah, but I can imagine that such a multidisciplinary approach is quite time-consuming, or maybe I should call it a logistical challenge, especially because in the ICU, decisions follow up really quickly. You have to, it's almost a continuous...
Yeah.
So is that possible? How does one arrange that?
It is challenging indeed, but I think it is crucial.
Yeah.
And as Jeroen said, there are studies that when the multidisciplinary team is well bonded, and it's not once a while, it's not 2 times a week or 3 times a week, if it is daily and it's by the bedside, there are studies and they have shown that we have a better antimicrobial stewardship, and we might have decreased consumption of antibiotics. We have results. And it's better for the patients. And so it is feasible.
Yeah, it's feasible. I think we all agree that if you have a patient that comes in with a very severe infection or with a septic shock, then you don't have time to discuss with the microbiologist. You're just going to start broad spectrum treatment. We need to do it because it's life-saving. But then at day 2, you have to reconsider, thinking, was this really an infection or was it inflammation of another kind? Do I have organ failure? Do I need the pharmacist to weigh in maybe for changing the dose or the dosing interval, et cetera, right? So all these things matter. And of course, we know a lot about this as intensivists, but we have to acknowledge that there's also a lot of knowledge that we don't have, and we need to have that buy-in from everybody around us.
And it is important, for example, the lab to give us data about, not in general, what is the hospital, to have regularly updated data about our microorganisms, about the flora in our ICU. So when we have a patient in our ICU for several days and we have a new septic episode, and we need to give a medical treatment without having the input of the multidisciplinary team to have an idea what we need to include in our empirical treatment. Surveillance culture of the patient, but also to have data of what is the resistance in the pattern of resistance, and to be updated.
Yeah, communication is key. Yeah, well, it is in all hospital wards, of course, but it seems more urgent in the quick decision making on the ICU.
Exactly, quick decision making, and we need all this information. And it's not always easy. This multidisciplinary approach. You need to work with the other teams and gain trust between.
I think that's an interesting point because it's what happens obviously is logical. We're clinicians, so we're treating a patient bedside. So what are the most important things that we look at is what's organ failure? How's that developing? What does the patient look like? I mean, what are the lab results? The micro will maybe focus on what you find in the lab. So I see nothing growing in the lab, and that sometimes can create some tension. It's like, so I think what we should do, or we should try, and especially for the antimicrobial stewards that have to influence decision making in the ICU, they have to understand the clinical viewpoint. And that's why I think Despoina said rightly, clinical ward rounds are very important. We want the micro to see what the patients look like.
Exactly.
Right? We accept that they're not going to be doing the clinical examination or putting in a central line, but they will have to see what the patient looks like.
Do you get feedback from them? How do they experience it, seeing the patient? Is it something that they didn't know they missed, or?
In my current hospital, as it works, with 3 times a week, it's not easily done, and as you said, it's a lot of burden. But this is something that I will strive to achieve. So to have an idea of this, that it's time critical, that they are different than the ward patients.
Yeah.
So little by little, I think we're going to understand more of their end, and they're going to understand more how the critically ill patients are.
Yeah.
Yeah.
So when looking at caring for the critically ill with an infection on the ICU, where would you like to see improvement coming? Would that be in the diagnostic process, or more in the therapeutic?
Well, you start.
Okay.
I got a question list.
What would help you?
I have a list as well. I think it's very important to have faster diagnostics, and with now the metagenomics, the faster, the multiplex rapid PCR test, I think this is the future. But it's not very close. We needed to have these tests validated compared to conventional cultures. But I'm expecting to be able in the future to give faster targeted treatment, and also to target a mechanism of resistance, and also not only with the faster diagnostic to be to give faster, more appropriate treatment, but also to be able to isolate or cohort when they are multidrug-resistant in these tests. And I will leave you the rest for you, because I have more things, but
No, it's a thing. I completely agree. So it comes at the start. Having rapid diagnostics really helps to quickly, as we call it, de-escalate. Right? You want to de-escalate treatment, go away from that broad spectrum, and go to targeted treatment. What I find is also low-hanging fruit, and as I said earlier, it's very difficult to stop physicians from prescribing antibiotics in very sick patients. You know, sometimes they may prescribe antibiotics to patients who, in the end, don't have an infection, right? That's possible. What's much more achievable is reducing the duration of treatment. So we still sometimes tend to treat, for example, pneumonia, community-acquired pneumonia for maybe 10 to 14 days. It's not necessary. The guideline shows that it's actually safe to stop after 5 days. If you have a very severely ill patients with abdominal sepsis, but the patient has been operated and source control is fine, then you can actually reduce the number of days of treatment. So there's actually really good evidence for that. But the evidence to practice gap is something that we really need to work on in ICU, especially, I think, in reducing the duration of treatment.
What is the cause of the gap, you think? Is it because they're so severely ill?
Insecurity, it is
Yeah,
being
Because
afraid.
they're so severely
My patient
ill.
might actually get worse again,
Yeah.
etc. But it's also peer pressure, right? I mean, you have some habits, right?
But the evidence comes from ICU patients, I believe.
It comes from trials. It comes from
trials with
non-inferior,
severely ill
it-
patients. Okay.
sorry.
Yeah, go ahead.
And on the opposite, when we need to prolong treatment, not to be afraid to prolong, but this is specific cases that the treatment should be prolonged.
Yeah.
And may I mention something, last thing? I think in the future is also optimization of antibiotic dosing.
Yeah.
If we manage to have therapeutic drug monitoring with faster turnaround times, and this is applied in a good structured antimicrobial stewardship program, not just TDM, I think we will be able to give more appropriate treatment, correct doses from the beginning, and as they say, dead bug don't mutate. So we don't we decrease resistance by correct dosing and shorter duration.
Yeah.
So, yeah,
And
so this
TDM can help.
pharmacokinetics, I mean, it's a whole thing we haven't talked much about, but it's obviously, it's so important in ICU because we have a different patient population. Again,
Yeah.
it's a patient population with a larger distributed volume. It's a patient population with much more organ failure. So, you know, looking really good at dosing, it's really important as a
drugs
part of our
work
job.
differently
Yeah.
in these patients.
They are
very
different.
Yeah,
Yeah. Yeah, so many challenges.
absolutely.
But
a lot of
it
challenges.
sounds a bit to me, if I may summarize a little bit, is that the field of ICU care or medicine has really pinpointed where the challenges lie, but also have pinpointed where the solutions may come from.
Yeah.
So does that feel correct for you, that you're on the way to improvement?
Well,
Even
little
further
by little.
improvement.
There's
Yeah.
the funny thing is that obviously now we know a lot, then we need to implement it, right? That's important. There's also new things coming on, right? We haven't,
Yes.
so we do a lot
yeah.
of ECMO patients, right? Patients on extracorporeal. We don't know anything about what happens.
Exactly.
Very little about what
Yeah.
happens during ECMO. How do doses, you know,
Yeah.
happen? Should we do with some antibiotics?
Yeah.
So there's a lot of unknowns out there.
It's a huge
Yes.
field of medicine.
Yeah, it's a really
even though we're just
challenging
talking about
subject.
infections, but yeah.
But
Yeah.
it's important that we have realized, because let's say 15 years ago, we might not have realized
Yeah.
all these challenges.
Yeah.
Yeah, yeah.
Yeah.
Well, this could be a reason for everyone to look back at the
Yeah.
on-demand recordings of the pre-ECMID day.
Exactly.
Yeah.
Thank you both so much for taking the time to come here at ESCMID Global, which I believe you'll probably have a full program anyway, but taking the time and coming here and explaining this in some more detail for our viewers. Thank you so much.
Thank you.
Thank you.
And thank you all for watching. We will be closing off for today, but we will be back tomorrow morning at 9, as you may expect from us in the meantime. We will be here at 9 a.m. and we will be welcoming Peter Openshaw for an interview. He is going to be talking to me a little bit more about his Meet the Expert session, in which he talks about recent advances in diagnostics and therapeutics regarding RSV. So tune in tomorrow morning at 9 a.m. We'll be fresh and sharp and ready for you with more information. See you then.